Right, well thank you. As you've already gathered, we've done a Cochrane review, so I'll crack straight on. Briefly to reiterate, so we did this review, I've described the main findings, but within this review we noticed that the blood pressure also falls in the usual or control arms of the studies included in the review, which is not unreasonable because they are receiving care. It's called usual care, but it's still care. We looked at the primary outcome of change in systolic blood pressure and diastolic blood pressure within that usual care arm alone to try and quantify the size of the drop, because we thought it would be interesting as basic information if one was planning a further intervention. And we used weight and mean differences and pooled these with inverse variance and adjusted for the correlation within patients. So the main findings were that overall, with nurse-led care, there was a drop of about 1.5 millimetres in systolic and diastolic blood pressure in the usual care arm, a bigger drop for pharmacist-led care, and overall that's a drop of about 3/2 millimetres of mercury in the usual care arm. Clearly a bigger drop in pharmacists, and that difference was significant. Usual care was different. In the majority of studies, it was simply what the doctor does. In a minority of studies, it was enhanced with some sort of educational intervention that was delivered to all the participants, all the participating professionals at the start of the study. And interestingly, where there was enhancement of usual care, we see quite significantly larger drops in the usual care arm in the blood pressure. So that little educational intervention affects your control arm of the study. Also, which I think is very interesting, we notice that where there's a low risk of outcome bias, we see the true full drop in blood pressure in the control arm over the course of the study. But where there was a high risk of outcome bias, so where the outcome pressures are being measured by the professional themselves or in an unblinded fashion, then there was a very little drop in the blood pressure in the usual care arms. So to wrap that up, the blood pressure falls on average by 3/2 millimetres of mercury in the usual care arms of these studies of interventions. It falls more where there's been some enhancement of that usual care, so that needs to be borne in mind in interpreting and designing these studies. The falls are significantly lower where there's a high risk of biased outcome assessment, and this might account for the finding of larger effect sizes in studies at high risk of bias, and might be part of the reason we should be cautious in interpreting them. So we just think these trends are important and should be considered when interpreting these trials or in preparing bids for future trials. Thank you for your attention.
So would the risk of bias phenomenon explain why in your earlier presentation you got a bigger effect with the pharmacist rather than nurse-led interventions?
There wasn't time in the first presentation to give you the sensitivity analysis by risk of bias, but actually those differences persist when we strip it down to the studies that we assess as having low risk of bias. So it's not the whole explanation, no.
I think this is interesting in the light of Suzanne's talk.
We talked about it last night. It's about the same order of magnitude drop. It's about 5 millimetres systolic. And I thought we were going to be looking at regression to the mean, but I'm not sure what we're looking at, to be perfectly honest. It needs quite a serious bit of thinking about it. Well, we don't know what your people were doing if they were going off and being treated. We imagine these people are being treated by their GP. But if so, it seems pretty ineffectual.
Richard?
Chris, I'm relieved to hear you mention regression to the mean. You've obviously thought about it.
Yes.
What is it that makes you feel that you're not just doing a meta-regression on regression to the mean?
Well, that's a very good point. But as I say, these are not genuinely placebo-controlled patients. They are receiving usual care from a medical professional. So we rather hoped and expected that in most healthcare settings that would lead to a drop in blood pressure over the study period. And there's obviously the Hawthorne effect, for example. People are in a study, the GP knows he's in a study, so he's probably going to be having a bit of a crack at the blood pressure. So bearing all those things in mind, it's interesting both the fact that the drop exists, that you can dichotomise it according to things like risk of bias or who's in the study. And also, in many ways, it's quite a small drop in some cases, where really you would expect to see some sort of result after 6 months, and you don't. So I think it's very complex.
Did the study inclusion criteria tend to include things like uncontrolled hypertension, blood pressure above target, and that kind of thing?
Yeah, the studies include populations with both controlled and uncontrolled hypertension, and that is a future sensitivity analysis that we need to do to split those two apart.
Okay, Chris, thank you very much.
Thank you.